everyone, and welcome. Welcome to our Whole of Consortium end of year update for the COVID-19 and Cancer Global Modelling Consortium. It's really wonderful to see you joining us. This is the first of two calls that we'll be having, another in 13 hours for colleagues in different time zones. And we're really grateful for your involvement and attendance today. So my name is Karen Cantwell. I'm in Sydney, Australia at the Daffodil Centre at the University of Sydney and Cancer Council, New South Wales. And I'd like to actually acknowledge all of the lands that you're all dialing in from worldwide and pay my respects to the traditional owners of the lands on which I'm standing in the Ku-ring-gai area of Sydney. So I also wanted to just acknowledge before we kick off, particularly Harriet Hui, who is here, and she's the Consortium Secretariat and Program Manager. And so Harriet is the person behind our Secretariat email, which is on the slide here. So for all follow-ups and for any suggestions or actions, please contact us via the COVID and Cancer email address on the screen. So today we've got a lot to get through. Our focus, as always on these calls, unfortunately has to be somewhat around updating because there is limited time for discussion, but we are going to try and reserve time for discussion on some key topics. Next slide, please, Harriet. Next slide, please. So we will go through some snapshots on some of the emerging work from each of the working groups, and there's a lot of exciting work going on. Freddie Bray is going to set the scene before that happens and tell us about some of the key developments in the consortium. And then we're hoping to reserve some time for open discussion on some important topics. Firstly, to take on board any suggestions for coordinating our internal engagement within the CCGMC. There are many, many active working groups now, but we're very happy to think about other methods of staying in touch and other ways that we can continue to increase the depth of our collaboration. We're then going to talk a little bit about a new initiative that we're setting up, which is a more coordinated approach to dissemination and engagement with the stakeholders who are using the results from the consortium. And we are going to be setting up a specific dissemination and knowledge translation working group chaired by Dr. Rami Miramal, who is on the CCGMC steering group, and there will be opportunities for everyone to express their interest in being involved in that active process. And then we're also looking to touch on plans and opportunities for next year. So as always, as we go through the update piece of the hour, please use the chat function to log any questions and comments, and Freddie and I will be moderating the session at the end, and we'll try our best to get to all who've commented. Next slide, please, Harriet. And this is just a quick overview of our agenda today. So I'll move next to introduce Professor Richard Sullivan and Julie Terode, who are going to give us an update on the overarching activities of the COVID-19 and Cancer Task Force, which of course the CCGMC is one component. Richard, thank you so much for joining us again today, and we're really excited to hear about the wider group of collaborators and activities of the task force. Over to you. Thanks, Richard.
Super, thank you so much, Karen. Very early good morning, ladies and gentlemen and friends from the UK. It's great to see a load of colleagues on board as well. I think Mika's on this call as well. So we're happy to take some questions at the end. This is a very, very fast run through of an awful lot of work. May we take the next slide, please? So I guess first the quick overview is there's still continuing expansion of the number of individuals who are involved in the task force now. It's grown to about 76 senior cancer centre directors, and we're now moving across 47 different countries. A huge range actually, from the most high income to those countries in the lowest income category. We've also expanded the number of projects, nearly 19 now, all at very different sizes. I'll be describing a few of those today. Publications are stratospheric. It's been incredible productivity. 67 publications now. Actually, it's not 11 near completion. I miscounted. It's actually 15 near completion. And one thing we'll do for next time is make sure there's a full bibliography to go with this. And I guess all the people working on the task force are working across some very multiple complex ecosystems and therapeutic geographies. And obviously the new variant strain is creating numerous problems all over the world in terms of the pandemic projections for 2022. Next slide, please. So diving straight in really to the working groups, you've heard a lot of this before. So this is the Health Survey Working Group. They're starting to publish the individual countries now. We're looking to do a meta-analysis in 2022 in Q1. Japan by far has the most complex and complete cohort. Again, I think one of the things we'll be thinking about is whether or not there are additional surveys of healthcare workforce, particularly projections around numbers and changes, maybe not so much here in the psychometric areas, but actually in terms of hard numbers, because we're seeing a lot of data coming out from centres now about some significant changes to workforce capacity as people are either moving, resigning or retiring. Next slide, please. The Silver Linings Work Group is continuing as well. This is led by Dorothy Lombe, who's now in New Zealand, actually. She was originally at Lusaka at the CDH. And there's some very exciting work that's coming on the back of this initial publication in eCancer. Again, it's pretty much finished now, and we're looking forward to a publication, I think, early next year on this. Next slide, please. Economic Impact Working Group, Michael Schlander, Nirmala Bhupati in Malaysia, Michael Schlander and DKFZ in Germany have been doing some extraordinary work. There are now 4 projects that have got off the ground, a lot of it based on some initial work, some done in Southeast Asia, and another piece down in the UK looking at both the direct and the indirect impacts of the pandemic on health economics of cancer. Productivity losses due to premature mortality and morbidity, and also impacts on out-of-pocket expenditure at the household level. We've had about 3 other groups now approach us to do work in this area in their own particular ecosystems, and this is something we're very keen on, is understanding what the socio-economic impact generally is of delays to diagnosis and also delays to treatment more generally in individual ecosystems. Next slide, please. The Research Impact Working Group, many of you will be aware that literally, I think it was last month's publication of the Lancet Oncology, we published this work on the global cancer research in the post-pandemic world, not just looking at the benchmark level of collaboration and cooperation, but also asking the question just how much work is going on between high income and low middle income countries, and it's pretty horrifyingly low. So whilst we talk the talk about global cancer research, the harsh reality is there's actually a very, very low baseline. And this is one of the areas I think we've got particular expertise in because of the algorithms and the bibliometric methods that have been developed. There are loads of wave 2 studies underway, sexing cancer research, looking at gender disparities, a major piece that's forming part of the Lancet Oncology Commission on Sub-Saharan Africa, looking at research ecosystems there. And a lot of this will help benchmark what is happening around the world to cancer research as the pandemic unfolds. Next slide, please. On the COVID-19 impact on cancer care, I think last time we talked about the non-pharmaceutical interventions and how they'd affected delays and in both diagnosis and in treatment. A big piece that came out very recently that the task force is involved in was this piece looking at planned cancer surgery for 15 tumour types across 61 countries. Nearly 466 different hospitals were involved in this. And I think this probably speaks to the strength of the task force, which is actually being able to get real data from real centres at the meso level at a relatively regular intervals across very, very different ecosystems and settings. And it just shows to prove that actually there are a lot of networks now being developed which are interlocking and can provide a very, I think, rich source of data, real world evidence to inform a lot of the modelling that's ongoing at the moment and also to validate the modelling. Next slide, please. And of course, as I said before, with the real world evidence, I think the issue really is we're seeing extraordinary variations from different cancer systems and healthcare systems, not just geographically, but also temporally as well. And the problem I think at the moment everyone's facing is the stop, the lockdown, the unlocking that's occurring. So Omicron obviously is causing huge lockdowns and delays in a lot of high-income countries. Increasingly, we're seeing emerging economies as well starting to lock down again. So any projections we've made in the last 3 or 4 months, we're literally having to throw away and start rethinking about where things are going in 2022. So this is going to be, I think, a big issue as we go into 2022. And I think it's very, very uncertain what a lot of the trajectories are going to look like around the world. Next slide, please. The COVID vaccines working group, again, big publication in Lancet Oncology, huge variation in terms of what vaccines are being used. In terms of looking at seroconverting, there are about 6 sub-studies now going on. It looks like hemato-oncology patients are the most at risk for not seroconverting, even with 2 vaccines and even with boosters. That work is being published at the moment. I know we've got a meta-analysis planned for Q1 next year. And we're also planning for Q1 next year to re-review vaccine equity within cancer patients based on this original benchmark data. So watch this space. And final slide, please. And just there with the engagement, again, we'll work very closely with Karen to look at this. Really, it's been driven by individuals. We've had 11 major webinars now, 4 symposiums as well, and we've got 2 planned for Q1 next year. So a lot of this is about disseminating this through multiple agencies. So recently we've had, the aortic meetings where a lot of dissemination was done, and also the London Global Cancer Week, just to give you 2 examples. And Karen, sorry, that was a very, very fast canter through, but I know you're up against time, so back to you.
No, that was great. Thank you so much, Richard. And yes, I think it's quite clear that some of the other working groups within the task force are really starting to generate, or have been generating, data that will be directly usable by this consortium. And I think part of our engagement strategy might be to really think about which of the other working groups in the task force perhaps we could forge stronger and more active links with as we go forward. So that was a brilliant whistle-stop tour, and it will be very important for us to continue to engage with all of your activities. So I'm going to now hand over to Dr. Freddie Bray from the International Agency of Research on Cancer. And Freddie's going to take us through the key highlights and achievements from 2021 for the consortium. Thanks so much, Freddie. Over to you.
Thank you, Karen. And this is going to be even quicker whistle-stop tour. If you can keep continuing, please, just once more. Yeah. So I think everyone's familiar with how the consortium started. So really, IARC and many other organisations, as Richard explained, there became members early on in the pandemic of the COVID-19 and Cancer Task Force. And as part of that, coming out of that, we started to look at in this consortium how we could examine risk for the longer term, looking at the impacts on cancer outcomes and so forth. So we wanted to assess the impact of the pandemic on the delivery of preventative screening cancer treatment services, and really then we partnered with whole sets of individuals, and we've been really trying to get as many partners and individuals who are experts within the global modelling community to become part of the consortium to support decision making in cancer control during and after the crisis. And of course we're still well into the crisis, but this is really a partnership among many, including the Canadian Partnership Against Cancer, International Cancer Screening Network, UICC, and of course the Daffodil Centre. And we've really tried to address some of the concerns around the pre-pandemic capacity and uptake of early diagnosis, screening and treatment capacity, and how that might lead to a stage shift, poor survival, increasing premature mortality, and so forth. And so I think it's been a really incredible experience, and we really have early on in the process tried to say we're going to look at this both in the short and the long term, recognizing that the strategies for recovery are going to be critical as countries move beyond the acute phase of the crisis. And of course we know that some countries are still within this, and it's always a challenge, but we're continuing to evolve and try and better understand the disease. Next, please. Yeah, so that's great. just an overview of the working groups, very briefly. The aim of the outset was to configure modelling platforms and teams that can provide more informed advice to governments as they rise to meet this challenge. We have a working group looking at quantifying impact of outcomes. So there's been a series of systematic reviews and looking at the risk of contracting or developing COVID-19 for people with pre-existing cancer diagnosis, whether patients with cancer, COVID-19 patients with cancer have a higher risk of COVID-related death than those without cancer. A working group led by the International Cancer Screening Network is looking at the impact across programs, particularly cervix, breast and colorectal cancer, and another looking at the non-pharmaceutical intervention strategies by countries, and such as lockdowns, and how that impacts on lifestyle changes, and perhaps increasing sedentary lifestyles impacts on the future burden of cancer. So there's a whole stream of work coming out from each of those working groups that we're going to sort of look at a little bit more in the next 45 minutes or so. Next, please. Yeah, and this is my last slide, so I'm being ultra fast here. Just to reflect, I guess, a little bit on the achievements of the consortium in this year and across the whole span of time, which is only 18 months. It seems a bit longer in a way. I mean, as we know, the overall pattern of the coronavirus pandemic thus far has been a series of COVID-19 waves, surges in new cases followed by declines, and certainly we couldn't predict at the time. We thought this was potentially, the pandemic was a transient thing of perhaps several months, of course, when we look back March, April in 2020, and then what is the impact on the disruption of services to cancer outcomes in the short and long terms. But now we see, of course, that we're moving into the fifth wave in some countries. We really need this consortium really for a number of years. I mean, we shouldn't predict that, but just looking at the highlights and achievements, then we have been able to bring in some resources and staff. We already have excellent resources within the Daffodil Centre and real expertise, but it is a coalition of the willing. We've managed to bring so many expert modelers and experts across multidisciplines to this space. Yeah, we're working with Cancer Research UK to try and really on the back of the international cancer benchmarking work, which is a survival benchmarking, of course, to try and look at how we can look at incidence and survival in the longer term in those countries, but extending that out. And we have formal collaborations with the cancer team within WHO, looking at systematic reviews. So there really needs to be, and there is that link between WHO and the consortium. In terms of engagement and collaborations, there's been a lot of work with Australia and Canada through this AUSCAN, as you say, the expert modelling group. We've had a lot of work on the systematic reviews, as I mentioned, establishing working groups with Andrew Obawe, for example, within WHO that is ongoing, and there's been a lot of collaborations and intersectional collaboration between the working groups, and that's been a lot of work, as we'll see on the screening activities as well. Thus far, it's a challenge publishing in this space, I guess, but there's a lot going on. As I mentioned, some of the systematic reviews are close to completion or have been already submitted, looking at COVID mortality and among cancer patients, the risk of COVID infection among cancer patients, and a specific systematic review looking at the changes in smoking behaviour during the pandemic and the lockdowns. Lastly, on the presentations, we've been quite active in terms of sending out the specific messages around the consortium, but also some of the activities from within. I won't go through all of these, but it's just to note that we've been invited to speak in many occasions in some of the major conferences, both internationally and nationally around the world. So of course, as I say, it's a collective. It's not any one individual or institution. It's really the expertise among everyone that's actually brought this consortium to life, and it continues to expand. So it's a big thank you to everyone for all their efforts in this. Next, please. Yeah, and this there was another slide. So this was just simply to highlight some of the publications, and this is really more for notes. I'm not going to go into any of these studies here. A lot of it's centered around the impact of screening. So there's one on looking at colonoscopy services and colorectal screening, another on the impact on COVID-19 on breast cancer screening, another on the impact of disruptions to the cervical cancer screening, and then a broader sweep on trying to look at optimization of recovery strategies during the pandemic in relation to cervical cancer screening. So that's only 4 of many, and there's many coming out, and Karen will speak to the observatory, a living evidence base that we're trying to create in due course. But hopefully, as Karen said, we're also going to look at how we can perhaps reconfigure the way we disseminate and communicate the consortium in the near future. But I think we're on a good track, and we're expanding, and hopefully this consortium is really sort of beginning to take its own activities and expanding them and becoming more and more relevant to coming out of this pandemic in a good way. Next, please. Okay, that's me. Thank you very much.
Thank you so much, Freddie. That's a really helpful scene setting. So I'm just going to quickly tell you about some of the developments in terms of the commission projects. And this, I guess, fits under the steering group is looking at an overarching funding strategy. And I want to acknowledge Julie Terode, who's joined our steering group and who's really taking the lead on this aspect. And acknowledge also Philippe Reutberg and Andre Obawi from WHO, who will be speaking today. And we are now moving some of our systematic reviews into the WHO process, and as such, they will inform WHO evidence reviews and general thinking in terms of positioning and understanding the impact of the crisis on cancer. I also wanted to mention a really wonderful development, which is that we have we're about to embark on a new commission project from Cancer Research UK, which will enable us to construct the first version of the COVID and Cancer Observatory. And it will be initially focused on HPV vaccination disruptions and disruptions to cervical cancer elimination in LMIC. But it will really allow us to develop a resource for the presentation of living model results and living systematic reviews, which we think will have implications ultimately far beyond HPV vaccination per se, and will really allow us to realise that vision of the observatory. So with grateful acknowledgement to CR UK, we expect to have now the first iteration of the observatory up and running in the early part of next year. Next slide, please, Harriet. And this slide really illustrates the concept of the observatory, that it's really a resource. It would be a key part of our dissemination strategy, and it would allow interactive engagement so that a policy decision maker or another stakeholder, clinician or a member of the community, can access information in a way that's relevant to them. It would be timely. It would be available ideally at a country level where relevant through the modelled analyses that we do, and it would enable them to essentially understand the implications of certain decisions that might be made and look at the possible futures that might be implied by those decisions. Next slide, please. And as I mentioned, the first iteration will in fact be based on the cervical cancer elimination delay modelling with a view to looking at the impact of delays in vaccine implementation, also incorporating disruptions to cervical screening and cancer treatment services. And this is just an illustration of the concept, building on some earlier work done to develop policy briefs for UNFPA. And you can see here some snapshot predictions for deaths that can be averted according to certain interventions. And this is at a country level. It happens to be for Papua New Guinea. And the idea is to extend these elimination projections so that it's actually more specifically around the impact of COVID delays and COVID recovery strategies. And again, it will be HPV vaccination and cervical cancer elimination as the first iteration of the observatory, but with a view to expanding this through 2022 to all of our other areas of work. Next slide, please, Harriet. So we're now like to move to the update on the working group activities. So we're now going to rapidly cycle through some key updates, starting with working group 1. And I'd like now to pass to Dr. Peter Coxeter. Oh, I'm sorry. Before that, I will go first to I believe it's Dr. Philippe Roitberg, who's speaking today on behalf of WHO. And Philippe will just be setting the scenes for the work that we're doing together on the COVID and cancer systematic reviews. And I believe Harriet, Philippe will be sharing the screen himself for his own slides. So we'll just need to enable you to share. Great.
Hello, Karen. Do you see my screen? Do you hear me?
I can hear you. We can see the screen, which I think is Harriet's screen, though.
No, I think it's Philippe's screen.
Oh, that's your screen. Fantastic. Over to you, Philippe.
Okay.
Very good.
So, good morning, dear friends, colleagues, and distinguished panelists. My name is Philippe Roitberg. As you know, I work at the WHO Cancer Team with Andrea Bavio and have the pleasure of collaborating through the Global Initiative for COVID. So just to frame the discussion today regarding the WHO perspective, so in order to set the stage, what we are doing here in WHO in terms of measuring impact of COVID on cancer, global response, how are we framing, and WHO signature solutions. In this regard, in the bottom line, we see that we now have been facing 1.8 million deaths in 2020 due to COVID, but as far as we know, 3 million deaths came from excess mortality. But this data that we see here, even though it sounds for us as something impressive and perhaps related to NCDs and the deaths that we are not seeing that are also related to COVID, this also reflects only data from Americas and Europe. So here we don't have also data from Africa and other continents. In this regard, what WHO does in terms of response is trying to act into some dimensions, which include the leadership, which are the global goods, and also the country support to offer the countries and our member states the support they expect from us. In this regard, related to service disruptions and the mitigation strategies, this is how dialogues the most with the partnership that Karen has just mentioned recently. In this regard, also WHO conducted a survey where we see here that for NCDs, this number of disruptions reduced from 42 to 32%, but even though it is still that much 2 years after COVID has started, which means that 1 out of 3 countries referred to having severe disruptions and 2 out of 5 having severe disruptions in supply side, demand side. These disruptions for sure are higher in low and medium income countries and perhaps unplanned more than intentional, and perhaps intentional in high income countries due to some organization strategic changes due to COVID. But how this reflects and also in the whole chain, this is how we want to see how this interplays with risk of death of patients contracting COVID-19, which is part of one of our collaborations. How undiagnosed patients related to delays in diagnosis and treatment also reflect in the mortality of our patients, and how also the behavior that you mentioned may also reflect about NCD's burden in the next years. So in the terms of impact response, we see that now we are living non-communication. This is a higher risk of developing severe COVID-19 disruptions. And we are now developing a model, as many of you know, to reflect and understand how this disruptions severely affect and perhaps how we project these deaths over the next years. And but mostly not only reflecting about the deaths, but how can we save lives in terms of diminishing these disruptions towards the mitigation strategy that we are now aim to reflect about the health impact of these mitigation strategies, because most of the publication available at the time we did our systematic review 1 year ago did not reflect outcomes related to COVID mitigation strategy. Much more, they described it, but they didn't give any impact size for us to project how these mitigation strategies might affect our patients and society. As we know, only 3% of the budget for emergency health response are related to NCDs, whereas we included it in 38% of the emergency healthcare support to COVID, and 10% of management in terms of NCDs only. We see that's related to these health emergency plans. So we are now trying to define a mitigation strategy, and those will be extremely relevant to have this normative guidance, and these publications are part of this to set national priorities and effectively support countries as they request. Also, lastly, according to vaccines consideration, Dr. Sullivan just mentioned a few minutes ago, and as we see now, we have the first phase 3 trial from Netherlands that are happening now, just emerging data from cancer patients exclusively vaccinated to understand the impact of vaccination according to different treatments and cancer sites. And we have also now new data from Veteran Affairs that might support this initiative. And this will be really, really relevant for us to understand how this how are we protecting our patients and how the uptake of vaccines are influencing this scenario also. So just to finish the discussion from our side, we have also set with countries, and we have mandate and we have agreement towards the World Health Assembly and commitment towards the global initiatives to reduce childhood cancer deaths and also to eliminate cervical cancer, one of the important, remarkable works that Karen is also conducting with Judith Roth. So in this regard, how do we achieve our goals if we do not have enough data to project how are we doing now and how can we do better? So in the end of the day, the discussion here must reflect collaboration as this group is. So civil society, professional societies, private sector, UN agencies, so advocating for evidence-based programs, aligning strategies with national programs, generating good quality evidence in priority cancer intervention, not only evidence, but good quality evidence, innovation, and support implementation through training. For the private sector, enable access to priority cancer products, expanding markets, and facilitate implementation research, support capacity building, and the leadership and country support that we are now offering to Mozambique, as we are now piloting to understand how this is also happening as far as we are now supporting their national cancer control plan implementation and monitoring these changes. So to provide normative guidance for cancer programs. Over to you. Thank you for the opportunity. Have a good day.
Thank you so much, Philippe. That was really helpful. And I think one of the major developments since we last met as a consortium is really developing our collaboration with the WHO team. And we're really delighted to be able, as CCGMC, to work together with you. I'm going to now pass to Dr. Peter Coxeter, who's been working as one of the central people in the systematic review team. Tomorrow it will be Dr. Richa Shah from IARC, but Peter is from the Daffodil Centre team, and he's involved in coordinating our WHO collaborative systematic reviews, and he's going to tell you a little bit about the process underway. Over to you. Thanks, Peter.
Thanks, Karen. Hi, everyone. Thanks for the opportunity to give an update today. I apologise for having some little instability issues with my video, so if everyone's happy if I proceed just with audio, that would generally appreciate that. So apologies. So look, following the previous CCGMC consortium-wide meeting in April, we're pleased to report an update on the 2 systematic reviews undertaken with Working Group 1. These reviews include, first, a review on the risks of contracting SARS-CoV-2 or developing COVID-19 for people with a pre-existing cancer diagnosis compared to those without cancer. Second, a review of the risk of COVID-19 related death for people with a pre-existing cancer diagnosis compared to those without cancer. These reviews are now complete and have been submitted to peer-reviewed journals. Importantly, the evaluation of the early evidence on the second question has also informed our approach for an update of this review, focusing on high quality evidence to try and determine the risk of COVID-19 related death for people with cancer and with more granularity. This work is being undertaken in collaboration with the CCGMC and the WHO, and we'll describe it in more detail in the following. Next slide, thanks, Harriet. Based on the previous work and discussions with both Andre and Philippe at the WHO, we have identified 3 research priorities that we are now tackling together as a collaborative systematic reviews. The first is the risk of COVID-19 related death for people with cancer. And this review aims to determine whether people with cancer are at higher risk of COVID-19 related death than people without cancer. So building on previous work, but with a focus on high quality evidence, this review aims to examine risks by cancer type, stage, time since diagnosis and treatment received, with adjustments for age and COVID-19 vaccination status where possible. The next 2 related reviews are firstly, the magnitude of cancer care delays and disruptions during the COVID-19 pandemic. And the aim of this review is to determine the impact of COVID-19 pandemic on delays and disruptions in cancer care, and the impact of strategies for mitigating delays and disruptions in cancer care due to the COVID-19 pandemic. So again, the review aim here is to determine the impact of strategies for mitigating delays and disruptions in cancer care due to COVID-19. Next slide, thanks, Harriet. In the next few slides, we'll discuss the population, intervention or exposure, comparator and outcomes for each of the 3 review topics. Firstly, for the risk of COVID-19 related death for people with cancer review, the included population are COVID-19 patients or the general population regardless of COVID-19 status. Exposures include those with cancer diagnosis within a specified period, or cancer treatment within a specified period, or current and active cancer as defined by the study. This is compared to those with no pre-existing cancer diagnosis, or no cancer treatment or diagnosis within a specified period, or no current or active cancer as defined by the study. Review outcomes are death from any cause or COVID-19 related death. Next slide, thanks, Harriet. Our second systematic review considers the magnitude of cancer care delays and disruptions during the COVID-19 pandemic. For this review, there are different study designs that would be applicable, which would determine the relevant population and outcome criteria. In particular, studies focusing on changes from the service level perspective could be considering service provision for screening, diagnostic, treatment or palliative care. By contrast, studies undertaken from the perspective of following up healthcare utilisation and access of specific individuals could include adults or children with a confirmed cancer diagnosis, under investigation for cancer, or eligible for screening. For both types of studies, the COVID-19 pandemic is the exposure, and the comparator is either the situation before the COVID-19 pandemic or different periods such as outbreak versus non-outbreak periods during the COVID-19 pandemic. Relevant study outcomes would also depend on the perspective. Service level outcomes include the time or duration to diagnosis, time or duration to treatment, the proportion or number of people diagnosed, proportion or number of people treated, the proportion or number of people screened or diagnosed through screening programs, screening participation, and admission or bed used to hospice in the context of palliative care. Individual level outcomes will include cancer stage distribution, survival, cancer mortality, and quality of life or pain, again, in the context of palliative care. Next slide, please, Harriet. For the final review, as mentioned before, we are interested in the impact of strategies for mitigating delays and disruptions in cancer care due to the COVID-19 pandemic. Analogous to the review on delays and disruptions themselves, studies to be considered for this review might also focus on changes on the level of the specific services or from the perspective of individuals. So the populations would be as in the second review just discussed. Eligible interventions include the implementation of strategies or programs focusing on cancer services or populations that reduces delays or disruptions in or receipt of cancer services. The intervention can be targeted to the whole population or specific to patients with cancer. And this might include masks, vaccination distancing, separate access to services from those with COVID, including cancers as part of emergency or essential services, special consideration for patients or populations with risk of cancer, such as transportation to care services, etc., and any intervention aimed to mitigate delays and disruptions. We are excluding telemedicine as it is not a definitive cancer diagnostic or treatment service. The comparison groups could comprise the period during the pandemic before the intervention was implemented, or a comparable setting where the intervention was not applied. Outcomes are also similar to the second review, and as you can see listed here, so I won't bother to go through those details again. Next slide, thanks, Harriet. So we would like to really acknowledge the great international team of CCGMC members who have expressed an interest and commitment to each of the 3 review topics and who have already been making great contributions to the title and abstract screening. This work could not be possible without them, so thank you all very much. Next slide, thanks, Harriet. So in terms of an update, to date, we have developed a comprehensive search strategy, which has retrieved around 17,000 records for the COVID-19 related death and cancer review, and approximately 5,000 records each for the cancer cares and disruptions and mitigation reviews. The review teams have reviewed and discussed a selected set of training abstracts to both pilot internal review processes and align reviewers' screening approaches with the eligibility criteria. The first batch of abstracts have now been circulated, and within a week or so, we've received around 1,500 abstracts that have been reviewed by at least one reviewer and around 1,000 records screened independently by 2 reviewers. Frequent and regular meetings occur between the central team and reviewers to discuss and review any emerging issues and discrepancies in the compiled results, but also to provide additional support as required. Again, we emphasise the importance of a collaborative approach for this and next stages of the review process. And in closing, we would just really look forward to hopefully sharing updated results with you at the next CCGMC meeting. Thank you.
Thank you so much, Peter. And I'd like to actually take a moment to acknowledge Isabel Sejoratamataran and Julia Steinberg from the various participating institutions who've had also a major role in setting up this review process. Okay, well, we're going to move on rapidly now to the screening working group and the various project teams. So we're going to hear first from the breast team, then the cervical team that's focused on high income country screening program disruptions, and the colorectal cancer screening team. So firstly, I'm going to turn now on behalf of the breast project team to Dr. Pietro Procopio, who's going to give us an update on their activities. Thanks, Pietro.
Thanks, Karen. My name is Pietro. Hi, everyone. I'm part of the Breast Cancer Policy and Evaluation team at the Daffodil Center. And on behalf of the group of the breast team, I'm going to give a very brief update on the activities that are going on in the group. The main activities have been evolving around modeling and systematic reviews, as you can expect. There was in the background data collection done on almost around 30 countries on mostly high and upper mid income. And that was done for gathering information about the screening programs and the disruption, of course. For what concerns the modeling, we are contributing to the global modeling platform as much as we can, and in parallel we started also a collaborative modeling with colleagues in Italy, aiming at evaluating the impact of the COVID disruption in Italian setting through our microsimulation model Policy One Breast. In regards to the systematic review, I'd just like to remind the aims that are, of course, documenting the disruption of the breast cancer screening programs around the world for the selected country, and gathering information about the participation rate since the start of the pandemic, and where available, where data permits, also about incidents. Next slide, please. And here I'm just summarizing these activities and highlighting the timelines for the main activities. And I'm just also putting there the contacts in case anyone's like to know more details about any of the projects that we are carrying out, or if any other collaboration is if any other member of the consortium is interested in collaborating for any kind of modeling. Thank you very much.
Thank you very much, Pietro. And I know the breast team, as for the other screening teams, are really immersed in an activity around doing global impact modelling. So again, for anyone that isn't involved in any of these activities, please don't hesitate to contact the relevant team. So next over to Associate Professor Megan Smith, who's going to tell us about cervical screening.
Thank you very much, Karen. So one of our recent highlights of our project team was organising and convening a 90-minute symposium session at the International Papillomavirus Conference, which was held virtually last month. The session brought together 8 international experts in cervical screening programs, epidemiology, economics and modelling for both presentations and a panel discussion. And at the symposium, we provided case studies of real-world impacts on screening programs and how those programs managed through the pandemic, and also some insights from our modelling work on the effects of COVID-19 related disruptions to cervical cancer prevention, including groups who would be most at risk from those disruptions, and also potential recovery strategies that could assist in balancing clinical need with constrained resources. And in terms of our active research, following our previous publications in Preventive Medicine, the Journal of Medical Screening and Lancet Public Health, our current research activities are focused on 2 new modelled analyses. The first one is focusing on the health impacts of COVID-19 disruptions to primary cervical screening by time since last screen. And that's a model-based analysis for current and future disruptions, so that could potentially apply not only to COVID, but more broadly. And the second one will contribute cervical cancer estimates to the global CCGMC analysis. And so far we've been undertaking a review of screening program data across around 80 high-income countries. Thank you.
Thanks very much, Megan. And I'm now going to rapidly move on to an update from Working Group 2, the colorectal cancer team. So this will be delivered by Dr. Eleonora Folletto.
Thanks, Karen. On the next slide, you'll see a paper that was alluded to earlier in the presentation. It's our second paper from Working Group 2, and I'd just like to take a moment to acknowledge the technical team, but also the broader working group and their contributions to this work on how catch-up screening may affect colonoscopy services. And on the next slide, I really just wanted to share with you our next project that we've started. And as Karen mentioned, we're looking to estimate the global impact of colorectal cancer screening disruptions. We recently, at the beginning of the week, sent an email to the colorectal cancer working group where we've compiled the information from the scientific and grey literature on colorectal cancer screening programs, and we've put all this information into a dashboard that was shared with you, and we ask that if you do have any additional information about your country or any countries that you're aware of, that you share that with us so we can include that in our next project. And if you have any questions about that or didn't receive the email, please reach out to the Secretariat and we'll be happy to update you. Thank you very much, Karen.
Thank you very much, Eleonora. So moving along, we'll go to Working Group 3, and as the consortium members will recall, the main activity to date has really been around looking at smoking behaviour and exposures, although there's a lot of ongoing discussion extending this work to other cancer risk factors. So I'd like to hand over to Dr. Peter Surich, who's going to give us a sort of a final snapshot, I think, of a major piece of work now under review on smoking behaviour during COVID. Very much, Peter, and obviously that heterogeneity is going to be incredibly important to thinking about the country level modelling, which will come off the back of this in 2022, and this has been a key piece of work to enable that. So along with the global platforms that are being constructed by the groups, we also have a new group that's looking at a deep dive in countries where there are good data sources and existing models. So I'm going to hand back to Eleonora now to tell us about a new working group that's evolved quite organically between Australia and Canada. And we would say if there are others involved that would potentially be interested in joining this and eventually, of course, expanding this to other countries, do let us know. So Eleonora is here to tell us about AusCan. Thanks, Eleonora.
Thanks, Karen. Hello, everyone again. So what you'll see here are the project aims for AusCan. So we aim to perform detailed modelling of the pandemic's impact, but across screening, diagnosis and treatment. And as Karen mentioned, the focus initially is two countries, Canada and Australia, and 4 key cancer types: lung, breast, cervix and colorectal. We're planning on leveraging our existing microsimulation models, and this work will build on the work of Working Group 2 and the development of the CCGMC Global Modelling Platform. So in the next slide, you'll see outlined the team that we've currently brought together, the technical team that are from Australia and also from Canada, that include modelers, epidemiologists, clinicians, across both sides. And on the next slide, you will see the next steps for this group are to develop the technical protocol and confirm exactly what we are modelling and how we will approach this. We've also established a modelling advisory group. So in doing this, what we're aiming to do is include the clinical, policy and consumer views to provide real world on the ground perspectives and expertise to really guide the modelling and guide the scenarios that we are modelling. The current plan is for the first meeting of this policy advisory group to take place in February next year, and we look forward to updating you on this group's progress in future meetings. Thanks very much. Back to you, Karen.
Thanks very much, Eleonora. So just before we move to a very limited discussion in the remaining minutes, I want to re-emphasise, as we said at the beginning, we are setting up a new dissemination and KT knowledge translation group for the consortium findings that will be chaired by Rami Ramal. And Rami is very experienced in the knowledge translation area. And the idea here is this is an open call for interested consortium members to participate and to help us develop a concerted strategy and coordinated strategy for dissemination that will build on the observatory idea, but will also consider other ideas like communities of practice in different countries and other means by which we can really embed the findings and the evidence as it evolves in the policy decision-making process for countries. So please, if you're interested in, this is an open call for all, if you're interested in helping in this space, contact the consortium secretariat at the email shown. So just in the last few minutes, we are very, very interested. These calls are very much an update call. There's really not so much time for engagement with you. We're sorry about that, but we're very open to any suggestions now or in follow-up. So this is really an open section. If anyone would like to speak on how we coordinate better internally, how we engage with each other internally, suggestions on dissemination and knowledge translation itself, or any particular opportunities you want to flag, please do go ahead. That should be for 2022. So please, this is an open call. Freddie, I think is going to help me monitor, but I don't think we have any particular comments yet through the chat. Is that right, Freddie?
No, we don't have any specific comments or questions, Karen, but we've still got about 2.5 minutes. So if anyone wishes to speak, I think that's also another opportunity. As Karen says, it's an information piece mainly, but we'd like to see how we could reformulate things to make it more interactive in the future. So if you have any comments on that, you can get in touch with us, of course, through the consortium, or just please speak now. Thanks.
Thanks. Well, I don't see any hands up or anyone speaking, so thank you so much. We really appreciate all of you who spoke today. We appreciate everyone who's engaged. It does feel to us as though this is a true consortium now. There are so many individuals and institutions involved in the different working groups, and particularly the new exercise that was outlined with the systematic review has involved so many individuals around the world. So we're very grateful to all.
Sorry to interrupt. We have one question.
Oh, great.
From Julie Terode from King's College London. We have promoted the cancer community. Sorry, we have promoted to the cancer community ideas of how we get our publications and plans out to a broader community. That's a question. Julie, do you want to just, not sure if that's a question, do you want to formulate the question? Julie's there.
Hi, Freddie. Sorry, was it not clearly formulated? I thought it was an interesting question for us to ponder, because, of course, it's important for us as a cancer community to work together on this. But more importantly, is really getting the information out to policymakers and others working maybe on broader models for health impacts of COVID-19. So I thought maybe some of the audience might be having some good ideas about how we can access those key influencing groups.
Yeah, and I think I think the purpose of this new working group will really be to have a dedicated group who are meeting regularly and spending some time on these considerations. So even if people aren't able to engage as a member of the new dissemination working group, I'm sure they would welcome any thoughts and suggestions from any members. So please do send them in. I think there's a lot to think about. There's, as you say, coordinating as a cancer community, but there's also, yes, the broader agenda around all NCDs and the longer term implications. And I guess sadly, as Richard alluded to, our positioning as being here for the long term, seeing that this crisis would impact cancer control over a long period of time, is proving, I think, relevant. And so we expect to be fulfilling an important need for policymakers for some time to come. So I think on that note, thank you so much. Freddie, did you want to add any final words?
No, I think that's a great point. I mean, Richard also alluded to that. It's important. Maybe we should have a brainstorm about who the community is that we should be actually trying to address, and perhaps go to them and say we'd like to present our work, and yes, interact more than we are at the moment. But yeah, no more comments from me. It's been a good session.
Well, thank you so much, Freddie, for co-chairing this with me, and thank you to all our speakers and to all the members of the consortium. I hope everyone has a safe and rest of holiday season, and let's hope for better news on the COVID front next year. Thanks so much, and bye to all.